Good morning, students. In the series of lecture for viral hepatitis, today we shall be discussing the viral hepatitis E. Viral hepatitis E was earlier known as non-A, non-B hepatitis. Viral hepatitis E causes sporadic and epidemic proportion of jaundice cases in India. Recently, in 2012 and 2013, there had been an epidemic in the Odisha, in especially the Bhubaneswar, Cuttack and the Ganjam districts, wherein there were 800 plus cases and more than 100 deaths. It will not be impertinent to say here that during 1955, the first ever known epidemic of viral hepatitis swept through the Jamuna Bank of New Delhi and caused around 29,300 cases with 65 deaths. The viral hepatitis E attack is little different than the viral hepatitis A because it has a little longish incubation period and the effect of the disease severity is very high in the pregnant woman, and it is often resulting in fatality and complications leading to death of the death due to various obstetric reasons. With this preset, we would now discuss the epidemiology of viral hepatitis E. Hepatitis E is an infectious viral disease of the liver. It was earlier known as non-A, non-B hepatitis. HEV is a single-stranded RNA virus and it is mostly transmitted by the fecal-oral route. HEV outbreak was first documented in 1955 retrospectively in New Delhi, Jamuna Bank area. Mikhail Balayan identified the HEV in 1983 among the Soviet soldiers in Tashkent in Uzbekistan. Dr. Mikhail Balayan from the Academy of Science of Moscow went for an investigation of epidemic of jaundice among the Soviet soldiers in Tashkent, and there he ultimately wanted to find out the biology of non-A, non-B virus. At that time it was used to be known as non-A, non-B virus. He could not get any opening or any avenues to bring the virus to Moscow in his own laboratory. Therefore, he sacrificed and self-inoculated with the patient's samples and ultimately landed up in jaundice and hepatitis. In Moscow, he studied his own stool samples and urine samples and then finally ended up in finding out the HEV virus in 1983 and documented his papers. Hepatitis E virus is ubiquitous worldwide. There are 4 different genotypes which mainly decides the epidemiologic prevalence of the virus in different parts of the world. The genotype 1 is mostly present in the developing countries where the standards of hygiene sanitation is poor and mainly it causes the epidemics, whereas genotype 3 is prevalent in the highly developed and industrialized countries. It does not cause any epidemics. HEV causes estimated around 56,600 deaths, 3.4 million cases, symptomatic cases, and around 20 million asymptomatic cases around the world every year. The community attributes includes the seroprevalence rate at different parts of the globe. Highest seroprevalence is seen in the areas or in the countries where the hygiene sanitation standards is very poor. Over 60% of all HEV cases and 65% of all HEV deaths in the Southeast Asian and East Asian countries where the seroprevalence rate is found to be more than 25% or above. In Egypt, 50% of the children and individuals aged above 5 years are found seropositive. Most of the outbreaks are due to the fecal contamination of drinking water. Several other epidemics occurred in Indian subcontinent, USSR, China, Africa and Mexico. In USA and other non-endemic areas, low prevalence of anti-HEV, less than 2% is found in the healthy adult population. The HEV epidemics have been found to be characterized with the minimal person-to-person transmissions as has been observed. The sequence shows the global endemicity of the HIV around the world. There are three main regions. The dark brown areas are marked with a higher prevalence, and they are known as the hyperendemic zone, where the seropositivity is always around 25% or more. And these are mainly India, China, Southeast Asian and East Asian countries, and the African countries. Whereas the mesoendemic zone only marked with the brown areas are the USSR, part of US and South American countries, and they are marked with a less than 25% seropositivity rate. Whereas the white portions, that is marked with the low endemic areas, they are mostly the parts of North America, the Canada, Australia. There had been many epidemics around the world, but some of the important epidemics we show here in the slide. India had two epidemics: 1955 New Delhi epidemic, which caused around 29,300 affected, and there were approximately 65 deaths. Out of the 65 deaths, there are 35 deaths among the pregnant women. India again, in Jammu Kashmir, 1991, there was an epidemic involving 78,000 cases. Both these epidemics were waterborne, and mainly because of the fecal contamination of the drinking water supply. In China, had an exhaustive epidemic in 1991, wherein 119,000 people were involved. Pakistan had one in 1993 and 1994. Sudan had two, 2004 and 2014-15, wherein the insufficient supply of the safe drinking water was found to be the causative reason. Uganda had one epidemic in 2008. We talk about the viral morphology. It is a RNA virus, single-stranded, 27 nanometer in diameter, icosahedral capsids. It belongs to the family of Calciviridae and the genus of Hepavirus. It is fecal oral route transmitted, and it gets into intestine, from there to blood, and ultimately settle down in the liver tissues and hepatocytes, where it multiplies and causes the inflammation of the liver. And ultimately it is excreted through the bile and ultimately into the stool to further progress the transmission of the disease. We talk about the agent factor. I have already described that it is a ssRNA, or single-stranded RNA virus. It has 4 genotypes. Genotype 1 and 2 found in the humans, and 3 and 4 found in the animals. These animals are mainly the pigs, the deer, and maybe the wild boars. Genotype 1 is seen in Asia and Africa, whereas 2 is seen in Mexico and Nigeria, 3 is seen in Europe and North and South America, and 4 is again seen in Asia. Genotype 1 causes outbreaks in war zones, in the refugee camps, and in displaced personnel camps in the developing countries, and these are mostly due to the poor hygiene sanitation standards and contamination of the water supply. Genotype 2 has been less frequent, whereas in developed countries there can be sporadic cases of viral hepatitis C because of the genotype 3, and this is mainly because of consumption of undercooked, infected pork and pork products. Genotype 3 and 4 causes chronic hepatitis in the immunosuppressed personnel. The clinical perspective includes incubation period of an average of 40 days, but a range of 15 to 60 days. Case fatality rate is approximately 1 to 3% overall and 15 to 25% in the pregnant woman. The disease is severe with the increase of the age, and there can be chronic complication that would lead to the chronic active hepatitis. The period of communicability is unknown. As I have already said, that hepatitis E virus causes sporadic and epidemic viral hepatitis. Symptomatic infections are more common among the young adults of 15 to 40 years age group, those who are economically active. However, the disease is also common in the children, but in most of the cases, that is, in the children, the disease is asymptomatic and anictoric, and therefore often goes undiagnosed and unnoticed. The disease is transmitted, or the viral agent is transmitted through the fecal-oral route due to the fecal contamination of drinking water. Other transmission routes are foodborne transmission from ingestion of products from the infected pork and infected pork. It can also be a zoonotic disease or zoonotic transmissions in case of the swine house workers or abattoirs workers. Transfusion of infected blood products from an infected person, and vertical transmission from an infected pregnant woman to its fetus. The symptoms and signs include the anorexia or loss of appetite along with nausea, vomiting, and there may be induction of fever, mild to moderate degree, along with the headache, body ache, myalgia, weakness, and setting up of jaundice, which includes the yellow coloration of the conjunctiva and sclera, along with high colored urine and pale stool. The disease will be manifested with the enlarged tender liver on palpation, and there can be abdominal pain. Symptoms are largely indistinguishable from those experienced during the acute phase of any hepatic illness, and it is self-limiting and resolves within 1 to 2 weeks. The clinical complications are rare. However, in rare cases, the hepatitis may land into fulminant hepatitis and can get into the active hepatic failure, leading to fatal complications. Population mortality rate is approximately 0.5 to 0.4%. Fulminant hepatitis occur more frequently among the pregnant women. Pregnant women are at greater risk of obstetrical complications and mortality due to hepatitis C. Mortality rate in the pregnant women in their third trimester is 20% and above. Cases of chronic hepatitis E has been reported among the immunosuppressed, and reactivation of chronic hepatitis E has been reported in the immunocompromised patients. The laboratory diagnosis includes two different types of tests. The first one is detection of IgG and IgM against the HEV by ELISA and Western blot acid. The second one involves the reverse transcriptase polymerase chain reaction, or RT-PCR, to detect the HEV RNA in the stool or the urine sample, and immunoelectron microscopy to detect HEV in the patient's sample. Treatment. As such, no treatment can alter the course of acute hepatitis. However, supportive treatment, nutritious diet, and rest in bed will definitely help. In severe cases of acute hepatitis, antiviral agent, that is ribavirin, can be used, and it is used in 1000 milligram daily divided doses. However, ribavirin is not recommended for pregnant women and for the women who are planning to get pregnant in near future. The disease is usually self-limiting and does not require any hospitalization. However, in case of fulminant hepatitis with active hepatic failure, and as well as the infected pregnant woman, they would definitely require the help of hospitalization. Recovery is generally complete, and immunoglobulin prophylaxis is at present not available. Prevention of hepatitis E includes mainly the public health services in the form of standard public health water supplies and the standard sewage disposal. The quality standard for the public health water supply must include the source protection from the domestic industrial pollutants and as well as from open air defecation. The source should be identified with a borewell supply. Systematic water treatment to remove the physical, chemical, and biological impurities and pollutants to make the water completely purified before supply. Hazard-free distribution system to the community point should be there to make it free from contamination, and periodic water quality testing also to be done to ensure the safe water supply to the community. The standards for the sewage disposal includes water carriage system for the urban area, and the septic tanks for the rural area, and maintenance of the sewage lines in cities and towns, and periodic checking of the sewage line to avoid leakage and quick rectification of the leakage if there is any. There is a community prevention required for the hepatitis E virus, and the most important is the washing of hands. Washing of hands with soap and water before meal and after toilet needs to be emphasized and re-emphasized. Hygienic practice including the hand washing with soap and water before resuming into cooking practices or kind of food preparations or food handling. Avoid drinking water and ice from the unknown sources, and avoid eating uncooked, semi-cooked shellfish and seafoods, and avoid the raw fruits and uncooked salads can go a long way to reduce the transmission of hepatitis E. One needs to be vigilant when traveling to the endemic areas, especially the endemic countries like the Southeast Asian and East Asian countries and the African countries. Daily screening of the cooks and the food handlers in the face of an impending epidemic or a kind of threat with epidemic jaundice is also very important. Hygienic cooking and utensil cleaning practices needs to be reinforced. Pregnant women and immunocompromised patients need to be more proactive in self-protecting themselves to avoid contract hepatitis E virus. The community health promotion measures includes hand washing and advices on taking food from the hygienic sources. There is a need to advocacy to the community for to have purified bottled water when on a small vacation or a trip. Otherwise, they should carry water from their home. They must use spoon for feeding their own children, check street side food joint before eating. They need to be cautious while getting into areas or zones which are prone to epidemic jaundice, and although low in mortality, this epidemic incapacitates the many and therefore disrupt the economic conditions, economic activities within the community, resulting in poor financial conditions. Therefore, spreading of awareness on prevention of hepatitis E virus is important, and it would certainly help, and it would be taken by the community as such. Vaccine development. A recombinant viral protein vaccine was developed in 2001 in Nepal, and it was tested and found to be effective and immunogenic. The vaccine was started on production and utilization. However, the production was stopped because of low profitability and lack of market in the industrialized countries, especially in the North America and West European countries. China developed a vaccine called HEV-239 in 2012 and successfully produced and implemented in their own country, and it is marketed by the Innovax Biotech. The trade name is HEV-239. However, this vaccine has not been recommended for other countries by WHO. Therefore, this vaccine is not available in other countries at present. Lastly, I would like to show you a poster given by the Public Health Association of India on a public preventive charter for prevention and control of hepatitis E, having 6 counts, that is the safe water supply, standard sewage disposal system, personal protection measures, community protection measures, health education, and community advocacy for community protection and prevention against hepatitis E infection.